Thanks for having me. I've been traveling a lot, and my kids, I have a 9 and 12-year-old, they think I'm a big dork, but I like to take pictures of the audience with them waving to prove that I'm not. So maybe can you wave for me and I could take a picture for them? All right. Thank you. They'll no matter how many pictures though I show, they still are not happy with that. I wanted to start off with this tweet by Kanye West because I started the first design thinking program at a medical school, and I tell my daughter that all the time. She is unimpressed. I think she really just loves to make fun of me, and she just goes, "Dad, you just copied off of Stanford and IDEO. You're just a big phony." And I go, "Well, you don't have to be original. Kanye doesn't even think we need to be original." So there. I wanted to start off with this question this morning because we all, either as patients, either as clinicians or caregivers, have had like a real soul-crushing experience with healthcare. And why is this? How did we get there? How is our experience of healthcare so bad at times? I think part of it is that healthcare wasn't designed. It really just happened by accident. So we ended up with this crazy system where our employers pay for health insurance, where doctors don't get paid for value, but we get paid for doing more stuff to patients, where we as a country spend more than any other country on the planet, and yet there are millions of people who still can't access the healthcare system. We experience the repercussions of a system that wasn't designed in the services that we receive and the products and devices that we interact with, and in the spaces where we receive and deliver healthcare. So I want to go with you some of my favorite design fails in healthcare. Let's start off with the hospital gown. It hasn't been redesigned in decades. It's not a dignifying experience as a patient to put this on and your backside gets exposed. I'm putting it on myself. I don't even know how to put it on. It's very complicated. Recently, there's a great company called Careware. They work with students in the design school at Parsons in New York, and they came up with this redesign of the hospital gown. It's inspired by the kimono. It gives patients a little bit more dignity, and also as a clinician, I get access to the left anterior chest wall to do a cardiac exam. Look for these type of hacks. These are thermometers in our trauma bay. Our nurses used a marker to distinguish between the rectal thermometer and the oral thermometer, because as a patient, you don't want a rectal probe in your mouth. And these type of hacks represent an opportunity for a redesign. So look for these Sharpie hacks in where you live or where you work. There's a problem with interoperability. This is one of our residents. It's 2 o'clock in the morning. He's taking a picture of an X-ray and texting it to the on-call orthopedic surgeon because our EHRs and our imaging diagnostics don't communicate well with each other. So we use smartphones all the time. They're kind of like the duct tape of healthcare. We use them a lot for hacks. And that's why, as Dr. Lloyd Miner said, we end up using this thing to transmit knowledge all the time. The journalist Sarah Cliff calls it the cockroach of American medicine, and it's not going away anytime soon. Some of our devices, the user experience is poor. This is a life-saving device. It's a glide scope. We use it for difficult airway intubations. And then sometimes our residents are doing an intubation. They get a little stressed out and they forget how to turn this on because there's this small green dot right there, and that's how you turn it on and off. And we shouldn't, when seconds literally matter in this airway procedure, that we shouldn't figure out how to turn this thing on. Our diagnostic equipment, it's so difficult to operate. We develop these manuals for, this is an ultrasound machine, of how to turn on, scan, and transmit images. The sounds of the emergency department are loud. Telemetry monitors are constantly beeping. The ventilator machines are going off. We did this study with the architecture firm Kieran Timberlake. measuring over 2 weeks the average decibel levels. It got as high as 70 to 80 decibel levels. That's like standing on a highway, near a highway, or a vacuum cleaner going on, the sound of a vacuum cleaner in your living room. The bedpan, this is actually not a bad design of a product when it's used for its purpose, collecting feces and urine. It's a terrible design, though, when we use it for pelvic exams, and this is routinely done in the emergency department. So this is me empathizing what it's like to be a female going through a pelvic exam. This is a very vulnerable position for patients, and yet we routinely do this. Please, someone here, redesign this. John is our physician's assistant. Pictured here, this is his hallway workspace. He constantly gets interrupted, it's loud, he gets hit by stretchers. Worst part of it, he's right in front of a restroom, and the smells of an emergency room restroom are terrible. He has a worse seat in the house. This is a flow diagram of how we admit a patient to the hospital, of who to actually call. It's so frustrating. And so instead of spending time with patients, we're doing administrative tasks like this. One of our chief residents, he's a geek at heart, he got so frustrated, he coded an app to help our clinicians figure out who to call when admitting a patient to the hospital. Even design matters. Even the simple graphic design of this pain scale that we're all familiar with, the assumption is that 0 is normal for all patients. But there are certain patients who are living in chronic pain, who may never get to that 0 state. So what ended up happening was doctors like myself started prescribing a lot of narcotics to get all patients to that 0 state. It's a passion of mine to think about how to cure our terminally ill health system. And I think part of this cure involves changing this recipe of how doctors are made. This is how I was made. We take these standardized tests, these multiple choice questions, and they really determine who gets into the priesthood of doctoring. These are my parents. They brainwashed me at an early age to become a physician. They were immigrants from Korea. They worked in flea markets and gas stations so that I wouldn't have to. So I really had no choice to become a physician, but I am not a great student. I got a lot of C's. I suck at standardized tests, and I didn't really want to become a physician. And in the 3rd grade, I encountered really the first wicked problem in my life. I got a bad report card. So this is what I did. Because in a Korean immigrant household at that time, there was no such thing as getting your allowance withheld. We didn't get an allowance, and there's no such thing as getting grounded. My sister and I were latchkey kids, so I just found my mom's signature and forged it and solved my first wicked problem in life. So these bubble sheets still give me nightmares and give me sweats. I love this tweet by a cardiologist who admits that even he couldn't answer this anatomy question on a step 1 review book. So a lot of medical knowledge that we learn, they really just only test minutia. And organic chemistry and biochemistry pretty much have 0 relevance on my daily care of taking care of patients. Even the first 2 years of medical school, I've never had to recall the steps of the Krebs cycle during a trauma resuscitation. Medical training was very difficult. It was very difficult for me because it really destroyed my creativity. It was actually anti-creative, and it really beat any sort of imagination out of me. And so what ended up happening after training all those years, I ended up working in this emergency department, and I began to feel symptoms of burnout. I was physically, spiritually, emotionally exhausted. I was depressed about my job. It was hard for me to empathize with patients. I was very cynical and jaded. Half of us in my specialty experience symptoms of burnout, but what's weird is that none of us ever talk about burnout at all. And it's, even me saying this right now, I feel a little bit vulnerable because what if my colleagues listens to one of these talks? I think part of my personal pathophysiology or burnout was that I wasn't able to imagine a better state, that I didn't have this freedom to be creative, that was trapped, it was imprisoned. I love this definition of creativity by Ken Robinson. Some of you probably heard his TED Talk. It's the most popular one there is. There's over 50 million views. It's called Do Schools Kill Creativity? And we know what creativity looks like in the arts and humanities and in music and film, but what does creativity look like in healthcare? Can we actually be creative in healthcare? When we started this design thinking program about 4 years ago, it gave us that space to become creative. It helped us become better creative problem solvers. And like my daughter said, I have no original ideas, so a lot of my early inspiration came right here at Stanford, visiting the D School. I met this guy, David Janka, who's an instructor at the D School, and he introduced me to some of the spaces that he had, and I'm thinking, these are really cool spaces. If you notice, everything's on wheels, a lot of whiteboards, the classroom is flexible, they show their work, it's very colorful, and it looks a lot different from what we're used to in these classrooms. These are creativity killers. So what I did about 4 years ago, I took my medical students outside of these classrooms and started implanting them in design studios and having them think like a designer. And this is our 1, 2, 3-step process. We try to encourage students to develop empathy for the end user before coming up with a solution. And then when they understand the problem, to rapidly prototype a solution and then test that out right away with users, then iterate on that solution, then repeat that process over and over again. So this is how we apply design thinking in healthcare. What this community here has shown me is that patients are the expert of their own disease. When I came here a few years ago, I was blown away by how many patient speakers there were. And that really inspired us to bring in the patient into the conversation as much as possible in our design process. So we ran a workshop with our radiation oncology residents and introduced a patient with a cancer diagnosis. And the challenge was, how do we reduce fear and anxiety of patients undergoing radiation therapy? And I think this was the first time they've had this co-creation process. And this concept of co-creation was really struck home to me through this community. So we do that with our students. So not only do we encourage our students to design for patients, but also design with patients, and to, when they come up with a solution, to get immediate feedback. Physicians also are end users, and here are our students learning about their pain points, what keeps them up at night, what do they get frustrated with, to really understand the problems that clinicians face. And before they jump into the solution, they capture a lot of insights, because I think as physicians, we think we know the problem a lot and just try to ram a solution in, but we encourage our students to pause and reframe problems. And then we encourage them to prototype solutions, and prototyping can take many forms. It can take the form of a storyboard here, or screenshots of this is a smartphone app that helps medical students perform point-of-care ultrasound. This was done without writing one line of code. Or prototyping can take the form of skits, or it could take the form of, we use a lot of cardboard to build our prototypes. And when students ask me about my own pain points, what I was struggling with, I brought up this pain point. None of us, we make mistakes as physicians, and when we do, it just feels like we get punished for them. I hate getting this call. And I had a bad case where a patient in the emergency department diagnosed with sepsis had a bad outcome. I talked to our med students about this, and they've prototyped this initial solution. It led to this prototype, and they were inspired by Dr. Atul Gawande's checklist that have saved thousands of lives in the operating room, the simple analog checklist. And so this was their version of a checklist for sepsis patients in the emergency department, so that we do the critical actions before they leave the ER and go upstairs to an inpatient floor. So teaching design thinking has really changed our mindsets around how we solve problems, being able to prototype rapidly, think about the end user. A lot of us here are in the business of making doctors, and we need to ask ourselves this question of where healthcare is going. And I want to share maybe two insights where I think healthcare is going. One is that machines are smarter than us. This is an EKG read, and before I even pick up the EKG read, the computer has an interpretation. And this happened because a lot of us were missing STEMIs, or myocardial infarctions, in the emergency department. They're pretty accurate. And so I think anything that involves a pattern recognition, and this is going to be diagnostic imaging, that a machine's going to give that initial read first. And also, the delivery of care is going to become more digital, more virtual, more convenient for patients. It's also, the care is going to happen outside of the footprint of the hospital. This is an example of how patients are even having a virtual experience in the hospital. This is my colleague, Dr. Chandra, and she is triaging patients in the emergency room, and she's not even in the hospital because we found this to be a cost-efficient way of seeing patients faster. I think there's a real opportunity to fix this mess that we're in because the healthcare system is blowing up. And I believe in the power of human-centered design, that we can apply design and to actually map out what that future might look like. So I started off with this question of how might we heal our broken healthcare system, and I want to end with this one: how might we heal our communities? A lot of my framework for understanding how health is delivered, how the health of my patients comes in this doctor-patient relationship. But what I observed working in the emergency department in my city in Philadelphia, that some patients were just sicker than other patients, and it was based upon geographic location. They were more victims of violence, they suffered more for complications of diseases, and the research shows this. In our worst zip codes, people die at age 68, and our best zip code's 88. So that's a 20-year difference just by zip code. So zip code is the best predictor of how long you will live. And it really hit home that thinking about creating health, it's not going to happen within the walls of the hospital, what I do as a physician in the emergency department or in a clinic. And I love this definition of empathy by the designer Ellen Lupton. And this is, I think, the secret sauce to design thinking, to be able to recognize and share the mental state of others. I want to take a look at one of these zip codes in Philadelphia where patients have low life expectancies, and this is the zip code of Kensington. And what's the mental state of living near this vacant lot and these abandoned buildings? There's about 100,000 of them in our city. And a researcher, Dr. Charlie Brand, he's an epidemiologist at Columbia, did this nice randomized controlled trial by simply greening these vacant lots, had a physiological impact upon the residents living around them. The heart rates actually decreased. So we know that the non-medical factors, these social determinants of health, have the greatest impact upon how healthy people and communities are. And what's the mental state of a kid walking home from school to his house and walking through this tent encampment? I took this picture a couple of weeks ago. This is a tent encampment of young people living there who are addicted to heroin. Or what's it like being a father searching for his missing daughter in one of these tent encampments, or even someone living here? Kensington is at the center of the opioid crisis in Philadelphia. This was a community already ravaged by deep levels of poverty. So Philadelphia, we have great sports teams, the Eagles and the Sixers, and yet our claim to fame, unfortunately, is we also are the unhealthiest, largest city in the US with the highest levels of deep poverty. And what's it like coming here to McPherson Square Park and checking out a library at this book? And if you notice in the middle, there's 2 police officers and a police trailer. So this civic space feels more like a police state. because we have so many people coming here, even from different states, to inject heroin. And the librarians here have seen so many overdoses that they actually train themselves to administer Narcan within the library. So thinking about this community, thinking about how we can deliver health outside of the hospital, we partnered with community-based organizations, with residents, with an architecture firm called Kieran Timberlake, and we're launching this project this summer called CoLab Philadelphia. And we're thinking about how we can deliver services to the residents in this community. And this is a crazy idea. I was inspired by some architects at Kansas University and how they repurposed an Airstream trailer to engage with residents in their community. And you can do a lot with the Airstream trailer. There's food trucks, but you can also deliver medical services like doing HIV outreach or administering dental services. And you don't need a physical space always to engage with residents. So our plan is to repurpose an Airstream trailer like this one and put it in some of those spots where I showed you, like McPherson Square Park, and some of the engagements we could set up as a base camp and clean the park of a lot of the used syringes so kids could play safely. Or we can provide a fresh farm stand and allow residents to buy healthy fruits and vegetables, because this is one of our food deserts here. And I think even putting something beautiful and playful like that Airstream trailer would send a different message to the residents there, that this is not a police state, but that we care about this community. These are one of the other sites that we're looking at, and we can place this here and really test out maybe different services that the residents need and encourage economic investment, because unfortunately a lot of the storefronts here are storefronts that sell unhealthy food or they sell liquor. This is a community engagement meeting that we had last week, and what we heard from residents was that they are sick and tired of just being associated with the opioid epidemic, that they want their community to be healthier. And so when I think about designing for health, to me, it's really no different from designing for social justice or social impact or social equity, because what can be more unjust than being born into one of these zip codes and statistically dying 20 years earlier than residents in other parts of our city? And thinking about the blueprint for the future of health, I want clinicians of the future to not only think about treating the patients in front of them within their examination rooms, but also to think about how to care for the communities from where these patients are from. Thank you.
So thank you for talking about trauma-informed care without naming it. And I wonder with kind of everything that you've been saying and your understanding of trauma-informed care, I'm wondering how that shows up in your ER and when you're working with your colleagues, and if the folks that you work with have the same stance, or if you get any pushback with that and how those conversations go.
Great. In the emergency department, when delivering care, we only see that acute presentation of illness. And it's hard for us to understand the human behind that presentation of the acute illness. So for us, it's so meaningful to go into the communities where a lot of these patients come from and seeing actually the toxic impacts of their environments. And I don't get to see that just working in the hospital footprint. So that's why this project is so exciting for us, that it allows us to go in these communities where we don't have a presence in and interact with residents on their own turf, literally.